Hello, my name is Ian McCall, and this is tutorial 6 in the Ken Pava lecture series. What things are we going to look at tonight? Well, first of all, the differential diagnosis of transepithelial or transepidermal elimination. It's an interesting topic. Rather than think of the names of diseases that will do this, just think of anything abnormal that's deposited in the dermis in excessive amounts, then the body will try and expel it through the surface. So a whole variety of conditions will have the phenomenon of transepithelial elimination. I mean, any of the conditions that, say, have granulomas in the dermis, like sarcoid or granuloma angulare, they'll have transepidermal elimination. So will, say, lichen nitidus. So will all of the disorders of elastic tissue, where the elastic tissue is abnormal, the body tries to get rid of it. And we'll see that in the list of diseases when we go down and have a look at it down here. Then we're going to look at the dermatoses of amputees. So some importance. You then have an amputated stump, either below knee or above knee, sitting in cocooned inside a plastic container, and it sweats and it's subject to trauma, and hence there's a variety of things happen with the skin. The skin reacts by thickening, gets verrucous, can get eroded, gets ulcers, can get blisters. We'll come across the various things that can happen there as well. Then we have that old regular infantile eczema and recurrent infection. You know, we talked before about Wiskott-Aldrich and Job syndrome. I think we've got a picture of ataxia telangiectasia, and I think that was the excuse for putting it in here again. Then we're going to ask a few questions on migratory, necrolytic migratory erythema, differential diagnosis of lichen nitidus, conditions with keratinous plugs, sarcoid, differential diagnosis of scarring and non-scarring alopecia, and a bit on chloracne. And lastly, we'll, I think, trying to remember the last thing that we had on the list here. Yeah, we're going to look at necrolytic migratory erythema. Let me make this just a little bit bigger. Might be easier for us to look at this if I have it at that magnification. Let's look at the differential diagnosis of transepithelial or transepidermal elimination. Perforating diseases involve those where material is eliminated from the dermis through the epidermis to the outside surface of the skin. And some of the conditions listed below here all have abnormal material laid down in the dermis. I've said it can range from granulomatous material to degenerate elastic tissue and collagen, even to calcium. Now, the lesions tend to have a fairly characteristic picture. It doesn't matter what it is that the body's trying to get rid of. It tends to present as a papule on the skin with perhaps an umbilicated center or a plug of some sort there. And you can pick away the plug, you can remove it, and it will leave a crater. And that crater can, as I've said there, extend all the way down into the dermis. So we'll try and illustrate that as we go along. Now, I've also said there that the site at which the condition is found can be a good clue to the underlying diagnosis. I've said that, for example, perforating folliculitis that can be seen in some renal failure is usually seen in the extensor surfaces of the upper arms, the buttocks and the thighs. Kurl's disease, usually on the lower legs. Reactive perforating keratosis, usually at sites frequented by trauma, such as the back of the hands, the forearms, elbows, and knees. The perforating disease of human dialysis. I've got some good images of that. We'll go to it in a minute. But it seems to be a wraparound term to include examples of perforating folliculitis, Kurl's, and reactive perforating collagenoses. Usually seen in patients with chronic renal failure, and they usually have diabetes. Let me just flick into Global Skin Atlas to show you this case. Bear with me. Now we want to go for Girl's disease. Let me make that a little bit bigger as well. Girls. Yeah, this one. This was a lady who had chronic renal failure. She was on dialysis, and she'd have these lesions on her thighs and legs. And if we look at this in full size, you'll see that there's a sort of dale a little bit in the middle of some of them. There's also a keratin plug in some of them, or at least a plug of material. And if you were to pick that out, you'll get your crater. You may have some brown surrounding lesions here. These are just examples of the post-inflammatory hyperpigmentation when the lesion, when the material has been expelled, and the lesion then settles down. So that sort of picture is common to most of the cases of transepidermal elimination. We said there in this one of Girl's disease, it's understood to develop this perforating disease of human dialysis in between 4 and 10% of dialysis patients. The lesions primarily on the legs. Early lesions may be pustular, but late lesions resemble prurigo nodularis, as those particular ones did. Now, other conditions will give significant transepidermal elimination as well. And note, I've listed all of these conditions up here. I've mentioned sarcoidosis, with the granuloma that's thrown out, pseudoxanthoma elasticum, PXE. This is a disorder of elastic tissue, where the elastic tissue is thickened and fragmented, and the body tries to throw it out. The skin usually has a sort of chicken breast appearance to it. I think this is a link to one of the Derm Atlas cases, but it might be interesting just to look at the image. Yeah, that's it up there. These, what you're seeing here, these yellow papules here, and that's what gives that skin that chicken breast appearance. They've said confluent infiltrated yellow papules in the neck give a plucked chicken appearance. And remember that this abnormality of elastic tissue is also occurring in blood vessels in the internal elastic lamina. And these blood vessels can dilate and get aneurysms, and the aneurysms can rupture. And so they can present with strokes or, other vascular problems elsewhere. So if you see someone who is a young person who presents with a stroke at a very early age, have a good look at their neck, have a look at the sides of their neck, see if they've got any signs of pseudoxanthoma elasticum. Let's just knock that one out. Elastosis perforans serpiginosa, we've dealt with that before. Again, usually sides of the neck. You can see it in Down syndrome and a variety of other disorders. Fragile bone syndrome will have it as well. And it's usually circinate or annular lesions on the side of the neck with little perforating keratotic papules. Granuloma annulare. This, as I say, anytime you've got a granuloma, necrobiotic collagen in the dermis, the body tries to get rid of it. So you can have a perforating variant there. I think we've actually got a good example of that in Global Skin Atlas. Let me just go to a perforating GA. I think it's under P for perforating. There we go. Let's have a look at this one. The example I wanted to show was this one. View this full size. Yep. Look at these papules here. You can see there's a little dell in the middle. There may be a little keratin plug or a plug of material here, and this is where the body's trying to expel the necrobiotic collagen through the surface. I mean, I'd have difficulty diagnosing that as perforating granuloma annulare. I might have thought it was perforating sarcoid or perforating something with that surface. But just get that picture into your mind, because that'll indicate a perforating disorder of some kind. Lichen nitidus. Well, again, you've got that collection of lymphocytes and histiocytes just under the dermis with a thin overlying epidermis. And remember, the epidermis will have a clawed-like extension around that collection of lymphocytes and histiocytes in the papillary dermis. That image is a very common one to throw up in the derm path exam for the college. It's a very characteristic one. You either recognize it or you don't. Papular mucinosis, haven't seen many of those perforating. Rheumatoid, haven't seen many of those perforating either. Necrobiosis lipoidica, well, it might perforate. You're going to see that in your diabetics and the anterior shins. Calcinosis cutis certainly could. Any of the deposits of calcium under the skin can certainly perforate. But look at that. Malignant melanoma. Can't say I've seen many signs of those perforating. Look at this one, though. Chondrodermatitis nodularis helicis. That's the commonest of all, I think, the perforating disorders. Because this is where you've got a combination of trauma and ultraviolet light, a bit of ischemic necrosis, because it's the side that's the most protuberant part of the cartilage, usually in the ear that someone lies on. And they get a bit of ischemic necrosis, a bit of necrotic cartilage the body tries to expel through the surface. So it's a very common perforating disorder. Then all those infective causes, anything that's going to give collections in the dermis, the body will try and get rid of it, and so it may perforate. So we've mentioned about the plugs, and we've mentioned here, this was the site business that can be important. Perforating sarcoid and perforating GA are often seen in the dorsum of the hands. All right, so those are the two common ones, perforating within the dorsum of the hands. Papular mucinosis perforates on the lower legs. Rheumatoid nodules mainly around joints, obviously. Necrobiosis lipoidica, usually in the anterior shin. This picture, by the way, look at that annular papular eruption there, no scales. This was actinic granulomannulare. It was on a lady's neck. And the thing about actinic GA, John O'Brien first described this. But the thing about actinic GA is this bit here. If you biopsy in here, you'll find there's no elastic tissue. The elastic tissue goes. It's a disorder in which there's the elimination of the elastic tissue, and these papules just keep going on. This looks very granulomannulare-like if you were to biopsy it. But it's seen in sun-exposed areas, and it's some curious reaction, UV reaction to damaged elastic tissue and collagen. There was this one on infantile eczema and recurrent infections, and remember the Wiskott-Aldrich and Job syndrome that we spoke about before. Job syndrome especially, cold or hot abscesses, high IgE, the atopic eczema picture, and recurrent infections. But this was an excuse to show you ataxia telangiectasia. This was an example with excess telangiectatic vessels appearing on the sclera. And these patients, they may not develop these telangiectatic changes until about the age of 2 or 3, but around the same time, they'll also start to get cerebellar and balance problems. They're getting signs of CNS problems that come with this particular condition of ataxia telangiectasia. And they also get an atopic eczema-like picture. Letraseaweed disease, the histiocytosis, remember that's going to look like diarrheas and greasy brown papules, usually in seborrheic areas. There was a little article here on in the archives on, I think, atopic dermatitis in Jobs. You can have a little look at it yourself a bit later, but this was the article here. Large cold and recurrent staph abscesses, intermittent bacterial and yeast infections, atopic dermatitis, and impaired neutrophil chemotaxis. So this is why they tend to get infections in these conditions. There's usually some impairment of the way in which infections fought, and that's in neutrophil chemotaxis. Let's go back. Dermatoses of amputees. I've already said that the big problem here is occlusion, friction, sweating, rubbing, and so the skin can react in a variety of ways. We've said verrucous hyperplasia, follicular plugging, but there's this little lot here. Mechanically induced blisters, follicular keratoses, epidermoid cysts, stumpedema syndrome, acroangiodermatitis, that's the pseudocaposi's thing. So it's going to be a purpley red papular eruption, that can occur on the surface, but it's pseudokyphosis, acroangiodermatitis, and there's that verrucous hyperplasia. There was a picture here that I got from the net. You can see the verrucous surface and the end of that one there. Seems to be some erosions here. Not quite sure what that one's meant to show. And there just seems to be some thickened papules have occurred here. I don't see the stump. There was this little article that I found that I think you might be interested in. You know, if you want practical tips on the management or on the advice you can give to someone who's got problems, then this particular article by Helen Connor, I think she's a physiotherapist, I found really quite useful. Let me just enlarge it a bit. Remember, the residual limb is not designed to weight bearing. So the various problems of pressure and friction. She goes on and looks at all the other factors that play a part in contributing to skin disorders and gives some good practical advice on the management. So I'd print this out, I'd give it to a patient, or at least select some bits of it that you think would be important. But we tend to forget about these common things when we might just give a cream and say use this on the rash, but we really have to look at all of these other factors that may prevent the rashes developing in the first place. Chloracne. Chloracne is where you have bad acne in unusual places. So if you see what you think is bad acne in most unusual places, consider chloracne. The classic feature of it are these black follicular plugs and papules, mainly over cheeks, behind the ears, and, remember I said unusual places, surprisingly on the scrotum. Now, you can see it in people who are involved in manufacturing PVC, polyvinyl chloride compounds, but also in people who are exposed to dioxins. And most of the catastrophes with dioxin exposure have occurred in factories where there have been explosions, and then patients have had the problem, they've ingested dioxins, and they've had lesions that have persisted from 6 months to 30 years. They said here the initial lesions are comedial, progresses to form yellow cysts, cold abscesses, as well as inflammatory staph infections. But there's much less inflammation than in cystic acne. And scarring is not uncommon. That should be PCT. Porphyria cutaneous tarda may also be seen in patients suffering from this condition. And GA-like lesions in the dorsum of the hands and hyperpigmentation can be seen in late cases. Remember that Ukrainian prime minister who unfortunately went to have dinner with someone from the KGB and they put dioxins in his soup. And you can see that if you just Google it on the net, you'll see the terrible damage that the dioxins and the chloracne induced to this man's appearance. This slide here shows you the types of follicular, the prominence of the comedones that you'll in fact see in chloracne. What about sarcoidosis? Sarcoidosis in the face, usually annular lesions, like this one here, and that purpley color, much more purple than granuloma annulare. But they're saying 4 types can be seen in the face. The commonest is that annular type, but you can also see the angiolupoid type, and this one. This one's the one I want to remember, lupus pernio. This is where you'll get a bluey purple infiltration of the tip of the nose or the lobe, the ear lobes or the like. That's why it's called lupus pernio, because it's like cold injury, chilblain type injury. And people who have that lupus pernio type of sarcoid, they're much more likely to have granulomas and bone cysts in the fingers. And also, they can get chronic ocular lesions with iritis and even blindness. So, if you've got someone with lupus pernio, go looking for problems with sarcoidosis elsewhere. And these are some of the other unusual types of sarcoid. Remember scar sarcoid. This is where you can get scars from a variety of causes, and yet the sarcoid infiltrates will occur in these scars, and it can also even include tattoos. There's an ichthyosiform variant of sarcoidosis, and that looks like ichthyosis vulgaris. So they're presenting with skin-colored scaly eruption. You don't normally think of sarcoid in those circumstances, but there is this ichthyosiform variant. Then there's alopecia. Now, that can either be due to plaques extending into the scalp giving hair loss, or lesions that look like small areas of alopecia areata. Then something that looks like a morphiiform BCC, morphiiform sarcoid. There's marked scarring with the sarcoid, and that's what gives that morphea white-like lesion. Usually plaque-like, occasionally you can even get linear morphiiform sarcoid. Then mucosal sarcoid involving the mouth, and generally if it does, it's the hard palate that's involved. Subcutaneous sarcoid, well, sarcoid subcutaneous. Deep-seated nodules, though, found on the trunk and extremities, rarely on the face. The lupus pernio one, which is spoken about. Ulcerative sarcoid, very rare variant. The plaques can ulcerate. And really, I've said that you're only going to diagnose that by biopsy. Then hypopigmented sarcoid. Now, that might look very much like, what can it look like? It could look like the white spot variant of, say, lichen lichen sclerosus. It could look like pityriasis versicolor, and it might even look like pit lichenoides with white scarring. But this hypopigmented sarcoid, so remember it may look unusual as well. Mostly the lesions look macular, but sometimes on touch a dermal component can be felt. So just remember these unusual presentations of sarcoid, especially the ichthyosiform one, especially the lupus pernio one. And remember the hypopigmented variant as well. Now the differential diagnosis of scarring and non-scarring alopecia. Well, the non-scarring alopecias are essentially androgenetic alopecia, alopecia areata, and trichotillomania and telogen effluvium. But you've got some of these other ones that are non-scarring, such as trichotillomania, pooling, fungal infections, but there'll usually be redness and scaling here. Anagen effluvium, usually in young children, curious condition. The loose anagen syndrome, sorry, that's the one I'm thinking of. Anagen effluvium can occur with cytotoxic drugs and other things like that. Secondary syphilis, that moth-eaten look that you can get in the scalp from secondary syphilis. Classic, just go looking for it. But if we're going to look at the scarring types of alopecia, how do you know that scarring's occurred? Because there's no opening of hair follicles on that surface. The surface will be bald without those openings of hair follicles. It can be bald in alopecia areata, but you've still got the opening of the follicles there. There can be congenital types of scarring alopecia, such as aplasia cutis or alopecia triangularis. There can be traumatic factors that cause scarring alopecia. Some people having skin cancer surgery. Some infections, such as zoster, can cause significant scarring that you'll have permanent alopecia there. Carrion is the one you've got to watch. Remember the reaction to an animal fungus, the gross inflammatory reaction. That can give scarring and will give scarring, so you've got to get them and oral steroids quickly if you make a diagnosis of this, as well as an oral antifungal. And then, what else have we got? Tick bites. Well, that gives a temporary alopecia in my book. It doesn't really give a scarring alopecia. Sometimes you can recognize some unusual types of scarring alopecia when it's due to, say, necrobiosis lipoidica or PCT or discoid lupus or metastatic tumor. And then there's these other things. They say incontinentia pigmenti. That gives rise to, in say a female who's recovered from it, they may just have abnormal teeth, the loss of some central frontal teeth. They may have areas of scarring alopecia on the scalp. So if you've got a child that you think's got incontinentia pigmenti, have a good look at the mother and look at those areas. Dystrophic EB, that's certainly obviously it's a scarring type of EB. These three, pemphigus, bullous pemphigoid, you don't usually get a scarring alopecia with those. Mucosal pemphigoid, you might. I've said there, what are the other concomitant findings of incontinentia pigmenti? If you're going to do this, put your little answers, put some text in here, then go down the bottom and press submit, and then you'll be given the answers. So what are the concomitant findings of incontinentia pigmenti? We said in the mother, look for the baldness, look for the abnormal teeth. In a child, look for post-inflammatory hyper or even hypopigmentation that's there. Look for, it depends on the stage, but look for the warty papules that are occurring on Blaschko's lines as well. And check the teeth and scalp of any child as well. What's the hair color sign on scalp cysts, and what might it indicate? The hair color sign on scalp cysts. Sure, I think it's something to do with ectopic brain. Sorry, let me just see. Oh, I want to go down to press submit. See what comes up. Okay, we don't have answers to question 1. Question 2, what's the hair color sign? It's a band of rapid hair growth surrounding a cyst-like structure in the scalp with often loss of hair over the cyst. It points to a diagnosis of heterotopic brain tissue. Whoa. And an encephalocele or a cutaneous meningioma. So you see that hair collar sign around a cyst on the scalp in a child. Make sure you do ultrasounds and x-rays to see if there's any connection with the underlying brain itself. Remember, the main thing with any congenital cystic mass in the scalp is to rule out an encephalocele. Do not stick a needle in it, or else you may get some CSF fluid out before doing the ultrasound and the x-rays, or some form of MRI scan, I would think. Okay, so remember that, the band of hair, the hair collar sign, and perhaps association with an encephalocele. Let's go back. Differential diagnosis of lichen nitidus. Well, lichen nitidus gives grouped, smooth top papules, particularly the lower abdomen, the arms. You can get linear variants. You can think of lichen planus as your differential, but usually they're bigger papules and purplish. You could think of lichen spinulosus, but here the papules, in lichen spinulosus, the papules are going to be raised, pointed, rough, more like big keratosis pilaris rather than the smooth top ones you get with lichen nitidus. So we've said here, usually lichen nitidus is discrete, shiny, flat-topped, uniform papule, size of a pinhead, may be found in plaques or a linear form because of the coplanising effect. Typically found lower abdominal, anterior abdominal wall, and on the genitals. Yeah, watch that on the shaft of the penis. You'll sometimes get lichen nitidus presenting there. But your differential diagnosis, flat warts, it's reasonable. Micropapular LP, but usually they're going to be bigger and violaceous. And itchy. Now, the lesions of lichen nitidus are not usually itchy. That's some importance. And occasionally lichen nitidus in the palms and soles can give hyperkeratotic plaques. Lichen striatus can resemble linear lichen planus. That's true. Papules are usually bigger. Scarring and damage to the nails can occur if the nail matrix is involved. I think lichen striatus, if it does involve the nail matrix, is more likely to cause scarring and damage to the nail than, say, lichen nitidus. Does nail involvement occur with lichen nitidus? I've never seen it. Let's say no. See what it says. Does nail involvement occur with lichen nitidus? Yes, it does. Oh, great. Sometimes with pitting, beading, longitudinal ridging, and sometimes nail fold inflammation, so you can get involvement of the nail fold as well. And pitting. Okay. No, we don't see enough lichen nitidus to be able to to clarify that, now what's the last condition we're going to look at? Necrolytic migratory erythema. This is quite an important condition because it can signify that the patient's got an underlying glucagonoma. And the glucagonoma is a tumor of the pancreas. It's part of the APUD cell tumors. They all produce various hormones, including glucagon. So what you get is a spreading, scaly rash that, let me just make that a little bit bigger, that often has little pustules in the edge of it. Now, in my experience, they're usually coming out from the groin, and sometimes you see them periorally as well. And in that situation, they can look like, acrodermatitis enteropathica, zinc deficiency. If it's mainly pustules coming out of the groin, and especially if there's a hypopyon level in the pustules, then the other condition is sorry, I just had a little mental block. Snedden-Wilkinson disease can look like that, with coming out the groin, with pustules with a hypopyon with a level in them, Snedden-Wilkinson. An IgA type, pemphigus type pattern. Some people also sort of think that there's a variant that's like a pustular psoriasis variant. I might, bear with me, let me just clarify Snedden-Wilkinson syndrome. I'll just have a quick look up that while you consider it, or I'll shout down the microphone that I've got it wrong. Bear with me a second. Snedden-Wilkinson syndrome, C subcorneal pustular dermatosis. Let's try for subcorneal pustular dermatosis then. 145, 146. What have we got about Snedden-Wilkinson? Sorry, I'm not picking this up very quickly. It's really talking about pyoderma gangrenosum in this particular area. No. All right, but remember, it's the hypopyon that's really the characteristic feature of subcorneal pustular dermatosis, and I'll get a little bit more detail and put it up here when I finish. So what are you going to see in necrolytic migratory erythema? Spreading, succinate, scaly eruption, pustular edge around the mouth, perianal areas, sometimes coming out of the flexus. Now, one of the reasons is that this looks like acrodermatitis enteropathica because there is zinc deficiency associated with this. There's sometimes amino acid deficiency associated with this condition as well. And they may have a painful glazed tongue with angular cheilitis. And the other thing is, if you biopsy this necrolytic migratory erythema, it's a very characteristic histopathology where you've got this pallor and necrotic changes in the keratinocytes in the upper third of the epidermis. They've also got hyperkeratosis and irregular epidermal acanthosis. Does glucagon itself cause the features of this rash? No, it doesn't. Remember I said it was the deficiencies of amino acids and some zinc. Let me just put zinc in here and then go down to submit and just see what I've got for the answers to that. No, the glucagon appears to cause amino acids, zinc, and essential fatty acid deficiencies because supplementation of these substances leads to improvement of the rash. Okay, so it's not due to the glucagon per se, but it's due to effects of the glucagon. We might have a quick glance at this particular reference if I can get it. It's this lesion down here. It's this particular case down here. Bear with me just while I go into this. I want to show you this one. It's one of the off-center folds. And what's the password? Try that one. The off-center fold can be quite useful at times. I used to have good links to it, but they went and changed the setup of it, and it made life much more difficult. See if we can view this large, and just see if we can view the case that way. No, can't really view it large enough, can we? Bear with me. We'll find the case itself. I want to show you the images of this. Nope, it's not that. It's not that either. That's the discussion aspect of it in this patient, because this patient had alcoholic liver disease, and they said this was pseudoglucogonoma syndrome, possibly related to zinc deficiency. Let's see these pictures. There we go. Let's just look at these larger images. Sorry, they're taking just a little bit to load here. But again, it's the succinate, it's the serpiginous pattern to these lesions that is important. If you have a good close look at them, they'll have a scaly edge to them, and there may well be some little pustules. But it's the same sort of lash that you can get in acrodermatitis enteropathica. Unusual type rash here, though. And let me just go back, and we'll see what they were saying here. Yeah, they were commenting on that, the pallor and the necrotic changes in the upper epidermis, the upper third of the epidermis, and the histopathology. They were also, in fact, sorry, let me just give you that histopathology again, because this is an important one. It's another one that you might get thrown at you in your exam. Let me just bring this one up. Yeah, some of that clear cell change is occurring up here in the epidermis, in the upper parts of the epidermis, upper third of the epidermis here. You can see all that clear cell change that's occurred with death of the keratinocytes. Maybe some apoptotic cells there as well. And you'll see that there's a degree of acanthosis in this condition as well. But remember, whenever you get scaly disorder, the epidermis has to be involved anyway. So just remember that histopathology in this particular condition as well. So the glucogonoma syndrome, necrolytic migratory erythema, little pustules in the advancing edge, scaly eruption, and remember that histopathology. It's just one of those conditions that they like asking about, and it's a lovely one for you to be able to make a diagnosis at some stage, because most people generally won't think of it. And if you're able to pick up that they've got a glucagon-producing tumor in their pancreas early, then you may in fact save their life. Okay, some interesting topics in there tonight: the old chloracne, the dermatosis of the amputees, and the transepidermal eliminations. Have a little read around some of those conditions, especially if there's any of these that you've not come across before or you're not sure about. Thank you very much.